Okay. We'll start the meeting just a couple of moments after time. Apologies for that. So, welcome everyone to Health, Housing, Adult Social Care Scrutiny Committee. We have no apologies this evening. Councillor Kelly is due to join us very imminently, but we will commence the meeting, and I will start by asking for any declarations of interest from members. Nope. Okay, we'll move on to minutes. We may have, do we have two sets or just the one? Just the one. Yeah, so on page 3, we've got the minutes from 13th of November. Has everybody seen those and is happy to approve them as a correct record? Yep. And I'm happy to take any matters arising from those minutes, should there be any? Nope. Okay. Oh, we're skittling through this. Right. Item 3 is public participation. We've got nobody registered to speak. So a quick reminder that the meeting is webcast and will be on the council website, viewed live and on demand. And then we will move to item number 4, which is Tees-Esk and Wear Valley's NHS Foundation Trust CQC inspection. And we welcome Zoe Campbell and Helen Day. If you'd like to come to the table. There's a presentation in the report. Would you like to talk us through that? Thank you.
Yes, Chair. We will assume that people have managed to have a chance to look through it, but just pick out some of the key parts and highlights. And having said that, I am now going to pass to my colleague Helen, who is going to talk you through the key points and highlights.
Evening, everybody, and thanks for having us. So the slide set you've sent is quite a high-level slide set. You know, I am absolutely both willing to take questions about York specific, as it is a kind of standard slide set, but we'll try and weave in some detail where we can. So the first slide just summarise where the CQC visited, and not all of these areas apply to us. So in terms of acute adult mental health wards, they did come to our adult mental health wards at Foss Park, but we don't have psychiatric intensive care in our services in North Yorkshire and York. They did visit our older people's wards at Foss Park as well. Moving on to adult learning disability wards, we don't have adult learning disability wards, so that didn't apply to us, although the team did visit our community adult learning disability teams. They also visited some of our community adult mental health teams. And then finally, they visited secure inpatient services, which is in the north of our patch, so wasn't relevant to us, although the learning for any of these visits is shared across the organisation. The next slide, which is titled Previous CQC Ratings, I'm actually going to just skip over that because it's repeated on the next one with more relevance. But just to hold that thought, that you can see that the overall rating from the previous inspection requires improvement. So the following slide compares two tables, and I appreciate they can look quite busy. But just a reminder that the CQC inspect NHS organisations, well, anywhere they're inspecting, under 5 key domains. So are we safe? Are we effective? Are we caring? Are we responsive? And is the organisation well led? And all these scores and markers give a cumulative overall rating for individual services and then for the trust. I think if you're looking at it in colour, the most striking thing, without going into every single tile and every single service, is you'll see that the colours, the reds and the ambers, have improved a lot to more green and some amber. Not all services, when you move across to the October 2023 tiles were inspected. So you'll see that the overall score, that very right-hand column, if you look at the date there, you'll see the ones that haven't been re-inspected, such as CAMS community services and older people's community services. The safe domain is the one that requires improvement in most of our areas. That remains and requires improvement. In the main, that relates to safe staffing and for inpatient areas, concerns around governance, around things like restrictive intervention and restrictive practices. In terms of safe staffing, that is not out with any other NHS organisation, and it's a common theme that comes up. And also links broadly to the well-led domain and ongoing improvements which are being made around governance in the organisation and the investigation of serious incidents. So moving on to the next slide, this is just a different way of cutting the data, which makes it easier. Just to summarise, 3 overall core services improved. MHSOP, sorry about the abbreviations, is Mental Health Services for Older People. ALD inpatient is Adult Learning Disability, and Secure Inpatient Services. 3 core services remained the same, Adult Mental Health Acute and Psychiatric Intensive Care Unit, Adult Mental Health Community and Adult Learning Disability Community. The 12 domains across the core services have improved, 15 have remained the same, and 10 are good, and only three where the rating has decreased. So again, the next slide is some more high-level figures which can help bring the report to life. The improvement from the 2021 is that 7 out of 11 of our services are now rated overall as good, and 4 areas are rated requires improvement. This is a significant change, as in the last inspection, we did have services rated as inadequate, both within domains, and secure inpatient services were rated inadequate overall. This time, all services were rated good for caring. That might be something that you think, well, we should take that for granted, that NHS services should be caring. Unfortunately, in the 2021 report, we did have some services that were rated requires improvement. So we're incredibly pleased now that the organisation is rated good for caring throughout. We had no warning notices served as a result of this inspection. So warning notices might take the form of immediate escalation at the point of inspection from the Chief Inspector to the Chief Executive, or formal legal warning notices served at the point of inspection. So we had none of those, which again is an improvement on the 2021 position. The next slide just lists some positives there. In terms of time, I won't read them all, but obviously there's some really great things to read, really positive changes within the organisation, not least around leadership, culture and governance, which has been the point of some spotlight over the last few years. In terms of area that we do need to improve on, they are listed there, and I can say that there's been positive improvement on all of those. So one of the biggest concerns for us was the backlog that had built up within the organisation around the investigation of serious incident, and therefore relating to our duty of candour responsibilities to patients and their families. That serious incident backlog is now under control, with a trajectory to complete the backlog in the very near future. And alongside implementing the new patient safety incident response framework, we'll be moving to a much more learning focused, duty of candour, transparent approach to the investigation of incidents along with the wider NHS. We have improvements in staffing, including retention and turnover, and also looking at different ways of working rather than relying on the traditional number-based approach to measuring safety. And just some other bits and pieces fall under staffing around training, supervision, etc. There's now processes in place addressing all of those. We continue to need to improve on waiting times in several of our services, both locally and across the trust. And each of those services has very specific and detailed improvement plans. And then finally, the trust did not have a robust physical health monitoring strategy, and that is now in place. So in terms of how the CQC tell us what they think we should do, we categorise them into must-do actions. They're non-negotiable and we need to report on those pretty soon after the inspection. And then they also have should-do actions, which we don't ignore, but they're not attached to the urgency that the must-dos have. So we haven't compared it to the last inspection, but the total there of 38 must-dos is a significant reduction on the December 21 report. And actually, if you extrapolate what's relevant to our services in York and the wider patch across North Yorkshire, there are actually very few, and I can mention those at the end. So in summary, the CQC recognised that significant improvements have been made, and it was really positive to be part of how they were describing the culture and how staff were talking to them very openly about the differences that were being made. I personally started at Tube on a secondment from an acute organisation and chose to stay after I'd been supporting the forensic services. So for me, it was really fantastic to hear these changes. The patients and carers told the CQC that they received good care, and very importantly, it was kind and compassionate, and actually one of our priorities across the trust, but something that we're investing a lot of time in, particularly from my point of view, is just that overarching metric of feeling safe, whether you're in the inpatient or community. So we know there's more to do. We'll still keep a focus on, particularly on serious incidents and staffing, safe staffing, but we have had good investment, including in mental health services for older people. And we've got 27% more nurses than we did this time last year. I've mentioned the retention rate. Yeah, so that's the summary of the slides that I've sent you. I can give you, just for context, a couple of specifics so you can see the, I suppose, the minor, I don't want to downplay anything, but the relatively minor improvements that were needed specifically for York. So in terms of the must-dos for York, for inpatient services, this was very much around improvements in process around Section 17 leave. So this is patients going out on leave who are detained under the Mental Health Act. It wasn't that we didn't have the appropriate things in place, it was more to improve on our governance and record keeping. In MHSOP, the one must-do was actually around recording reasons for prone restraint, but we have a zero tolerance of prone restraint in older people. So although that was a must-do, we'd already made significant improvements in that. In terms of community services, it will come as no surprise that the must-dos are to continue focus on waiting times, staffing, because it all links to form an ongoing challenge with demand and capacity. In older people's community, the must-do is related, but it's specifically around memory services, and for adult learning disability community, again, it was around staffing and the relationship with demand and capacity.
Well, thank you so much for the update in the report, Helen and Zoe. I'd firstly just want to ask members if you've got any comments to make about the report, or yeah, Councillor Runciman.
Thank you, Helen, for your report, and very thorough it is too. Just a comment and a question, if I may. It's good to see that caring is coming out so well right across the board, and that's obviously a strength. But I noticed that safe isn't, and yet it's not mentioned in your comments on the following pages. And I wonder if you can just talk about that and what you might be doing to improve it. Thank you, Chair.
Thank you for the question. So predominantly safe is around safe staffing, and that's the common thread throughout the report. So the people plan, as we refer to it in Tees Esconway Valley, is focused on three main components. One is more people One is innovation and one is compassionate culture. So the more people is the more transactional. How do we recruit more? How do we work more with our higher education institutes, etc.? The compassionate culture is, well, when we recruit people, how do we keep them? And we are seeing a positive impact on our retention. So that's much more focus on continuing development, valuing staff, giving them the freedom to try things. And that links finally to the third category, which is innovation. So traditionally the NHS can get a little fixated on numbers rather than thinking about the right person, the right place to look after the right person. So different models of care delivery as well.
So do you think when they come back, and I'll ask you in a second when they're going to come back, that the safe column will go up to good like some of the others have?
How the CQC will be running their inspections going forward is actually changing, so you might not see a grid like this. But if we were, I would be really confident for our services in North Yorkshire, York and Selby. I won't talk for the northern part of Chewford, Durham and Tees Valley, but I would be confident it was, yes. Apologies, that's my phone in the background.
Sorry?
Yeah, just to kind of add a little bit more information on everything Helen said there. Obviously staffing into the NHS and indeed staffing into social care is an issue that's being faced nationally. So it is really difficult. It's a constant ongoing job. We're always out at live recruitment. But as Helen said, we are focusing very much on retaining the people that we currently have as well, and also on reducing sickness levels and things as well, which we have seen a slight reduction in across the North Yorkshire patch in particular. And that innovative bit is, you know, just looking at if we can't recruit the roles that historically we would have had in the NHS, then what are the new and different roles that we could have? But we are also, and I guess this is the main bit that I just wanted to build upon what Helen was saying, we're having conversations at the place level as well across York about, you know, this is a shared problem that we're all facing in health and social care. How do we work together to address it?
Yeah, it is a shared concern. So from our part, that acknowledgement's really important. I just want to follow up on staffing whilst we're on it, and then I'll bring other members in. The CQC report did mention staffing levels, which you've talked about. I know in your report the increase in nurses and the retention, which you're scoring well on as a trust. But some key points that came out of CQC are around unfamiliar staff, which I think you're answering, but in the way that you want to approach care, and also agency staff, and maybe if you could update us on the scale of agency staff or reliance on agency staff and what you think direction of travel can be in that regard.
I'm just going to jump in quickly first because this actually also picks up a point that was discussed when I was here last September. And there was one of the measures that we've put in place is to increase use of bank staff rather than agency. So we're doing a number of measures around that. And the thing that I'd mentioned in the September's meeting was that as an exec group, we'd agreed to increase the hourly rate for bank staff to encourage more people to register with us as bank. I was asked about what that hourly rate had increased to. It's actually just being reviewed at this moment in time again. So rather than give you old data, my colleagues in people culture and development will share the new rate with you when that's been agreed. And then over to Helen to talk more about agency.
Thank you. So just a high-level statement of assurance. Our temporary staffing department, if you like, only procures agency staff that have gone through comparable training as our own for the minimum things such as restrictive practice, restraint, etc. So that's kind of high-level reassurance. What we are doing in our patch is bringing agency staff more into the fold, because although we try and reduce agency staff for two main reasons. One is financial, and we can't get away from that, but we would never compromise finance over patient safety by decreasing nursing numbers. But one of them is there is a traditional reputation that maybe agency nurses aren't as committed, they may not give as good quality care. And we're very keen that we don't vilify agency nurses in that way. So what we do is work with our agencies to ensure that we have the same agency staff. So what I do as a director of nursing is track the number of different staff we have, or not have the number of different staff, and that they're coming from the same agency, so they get used to working with us. To support that, we are now offering them, well, it's kind of non-negotiable really, but in older people services, we're trialling bringing them into our supervision, so they get individual supervision and reflective practice like the substantive staff would get, and why shouldn't they? And the same offer of training. And then we also have amended our morning safety drill and safety briefing to make sure that any new staff are fully aware of the local processes. So we do have targets, trajectories to decrease agency staff, but they're not going away quickly. So it's about the safety mechanisms we put in place.
Okay, really appreciate that answer. If I could just briefly ask again in response about training of those staff, because in each chapter of the CQC report, when it's talked about staff and the care they're providing, it talks about their training, and the client patient experience is always referring to the training of the staff looking after them. Is that related to agency staff, and you have got a plan in place to train them, as you've just mentioned, with the same to the same level as your whole-time staff, or is it across the board whole-time staff need to access further training as well?
Yeah, ironically, the agency staff would come fully compliant with what we might refer to as statutory mandatory training. So our StatMand programme might be anything from fire training to restrictive interventions and restraint. And what the CQC refer to for some of our services throughout in relation to safe staffing is that when you're short-staffed, you'll always put the patient first and go to work rather than maybe go to a training session. So there's that to consider, and also accessibility of training, because we have a really big geography. So there's a significant trust-wide quality improvement piece of work going on around how we enable staff to access effectively, efficiently, statutory mandatory training. To ensure that we've always got staff on duty who are completely up to date with things like basic life support, restrictive intervention, we use a concept called Safe Today, which is effective use of electronic rostering. So we would never have a shift where nobody's up to date.
Thank you for that. Councillor
Supplementary
Vassy,
to that,
yeah.
Chair, yes. In the inspection report where training is mentioned, it also frequently couples that with the need for supervision. So I'm wondering if you can comment on that, because that pops up several times.
Yes, thank you. So supervision, there's two main types in mental health services. One is clinical supervision and one is management supervision. And the clinical supervision has a lot of emphasis put on it because of the need to reflect and debrief around obviously quite severe and complex cases. One of the challenges has been the recording of it, not necessarily the doing of it. So services have kept their own local records, for example, which might not pull through electronically. So there's there's a huge trust-wide piece of work looking at effective electronic software where this can be recorded and pulled through. But we monitor it monthly. We monitor it through our local governance systems.
Okay, thank you. I'll bring Councillor Rose in.
Thank you. Yeah, I think that your summary highlights a lot of the good things. There's no doubt that there have been improvements since previous times. And I think there are a lot of things to shout about positively. But I slightly disagree that it's a thorough report account or representation of the inspection report itself. I think that if you just read that, you wouldn't get an accurate reflection of everything that's in there, and repeat the points that have been made already around community mental health services for people with a learning disability or autism. Safe staffing is not enough staff, didn't know the people enough, didn't receive the basic training to keep them safe from avoidable harm. Nursing staff didn't always have enough staff in all teams. That's page 75 of the report. And in mandatory training, Positive and safe care level 1 update 55%, positive and safe care level 2 update 33%, positive and safe care level 2 33%. That's a really low number. It appreciating the reasons that we've talked about, but I think those are substantive gaps that should have been called out in the summary. I think that there are other areas, by the way, where safe staffing is called out as not a problem area. And I think that there's one of the area that I wanted to point out in particular, and we've talked about it before. We asked for some numbers a few months ago, and I haven't received them or haven't seen them, if I did receive them. But there's a whole area around, well, firstly, in the wards for people with a learning disability autism, it specifically says in access and discharge, the service was closed in new admissions at the time of inspection. There had been no recent admissions. People have been admitted from a local area. The findings from other key questions demonstrated governance process did not always operate well. There was bits around risk management not being managed properly, and I think it's good that there is good care. But if there are people who aren't in the system at all, they're receiving no care. And I think we've talked about this before in terms of diagnosis. It talks about that in a few places in here as well. Discrepancies in diagnostic wait times between different ICB areas. Lots of blockages at different stages of the diagnosis process. There's a whole bunch of stuff around 2-year waiting lists for neurodivergent assessments dependent on how services were commissioned. Those kind of things are scattered throughout, but in the summary on the first page around the legal requirements and the must take actions, the second one that it says there is the trust must ensure legally that people can access care which meets their needs by reducing waiting times. So again, for this not to be called out in the report and for this to be something that is, known widely as a particular challenge area, feels like an omission. And I think that the summary page that you've got around the must do and the should do actions doesn't say what any of those actions are. It kind of says there's a few in a few different areas, total of 38 must do and 56 should do. I guess the first comment is, I think the report should have been in more detail in some of those areas. The second one, I guess, is on those points in particular. That's a real concern for people who can't get the support they need today, who can't get into the system, who are expecting to wait 2 years plus. There's a whole comment around patients in crisis had their wait time reduced through the assessment pathway. That's sort of true, but they're having their wait time reduced because the others have an infinite wait time because they're not being seen at all. That's a huge problem area. So what's being done to tackle that pragmatically, not just must reduce wait times, which is not really an action. What does that look like in practice?
Yeah, no, that's absolutely fine. As I said, it's very high level, so really happy to take the questions because the devil's in the detail, isn't it? So if I take the first question, I think Zoe will probably comment on the waiting time figures, which you requested last time. In terms of you mentioning the training for our adult learning disability staff, the CQC report obviously generalises, just to reassure you that for us, our learning disability compliance is over 95% for appraisal and statutory mandatory training for our locality. So that's a reassuring thing. So I'll hand over to Zoe just to mention the waiting times, which is a big capacity and demand challenge.
Yeah, absolutely it is. So yeah, we do have patient tracker lists and we have systems and processes that we use to manage and make sure that we're constantly monitoring our waiting lists on a regular basis. And obviously as a care group board, we scrutinise that, and then it also conversations happen at exec group and board. However, that's so what really? So what are we doing about it? A lot of this, as Helen has said, is purely capacity demand issues. So we've mentioned the staffing issues, the vacancy rates that we're running with. Obviously, they're higher in some teams than others, and we can see a direct correlation between where we've got the longest waits across all of our specialisms and where we've got the highest number of staffing vacancies and capacity issues. So we've got that challenge that we're actively working on a regular basis in terms of trying to go out to recruit constantly, using agency where we have to, but making sure that that agency is safe, as Helen said before. Obviously, we've got kind of financial risks that we carry with use of agency as well, but we would never let that financial pressure override safety and quality for people who access our services. So there's a lot of work going on around that. I think it's probably worth just sharing that for children and young people, the number of referrals coming through the door just have been increasing month on month over the last year. And if we kind of look at a snapshot of just before Christmas to that where we were the year before, in that 12-month period, they've pretty much doubled. So that's the situation that we're in. We're having lots of conversations with system partners as well about what we can do about this and how can we actually make some changes in the pathways as well that people use to come into services to address some of that. None of these are quick fixes. There's nothing that we can implement tomorrow that are going to reduce the numbers on the waiting lists. And these are not to make excuses, but we do know that actually for some people who are on the waiting list, sometimes it's because people have exercised their right to choose and they choose not to have their assessment at the time at which we've offered it to them, which means they spend longer on the waiting list. I couldn't give you an idea at this moment in time about what proportion that is. And when we're talking about our biggest weights, we know are particularly around neuro assessments, so assessments for ADHD, and autism are where we have those biggest weights. And I can say for children, young people services, for neuro assessment, the average wait is 6 months, but there are some people who are waiting 1 to 2 years before they get that assessment. We do go through a kind of prioritising of people to make sure that those whose need is highest are brought forward and seen. And actually, even when somebody's already been given an appointment by a clinician, they still sit on the waiting list because they haven't yet been seen. So they are still counted in our numbers. Overall, for children, young people, again, I've just brought this figure because it was something that was discussed in September. So overall, with our CAM services, the average waiting time is a month in York, and the maximum is 7 months. And we've got 3 people who have had the longest waits there. So we are continually doing what we can to address this. But it is a challenge. It absolutely is a challenge. We'll continue to have the conversations about what we can do about getting more staff in. Can we have, is there additional funding available perhaps so that we can increase the services? But if we can't recruit the staff, then money isn't always the answer, is it? And I think it's probably just worth me mentioning as well that there is waiting well. So when people are on waiting lists, they're not just left on a waiting list and never contacted. We do have keep in touch processes that we put in place. So we're continually checking in with people. And actually quite often we find that that then causes reduction in waiting lists for some services because people's circumstances have changed or they've accessed something else. So as I say, I can't give you a response now that says, we're doing this and this will mean that our waiting lists will be halved within a few weeks, because these are really big, wicked, knotty problems that we're dealing with. But we are doing everything we can and we'll continue to keep that focus on.
Thank you. And it is worth acknowledging that it does talk about the support people are given whilst on the waiting list, and that these are primarily driven by funding and staffing challenges that are national problems. And I won't say any more on that point, but people know where I'm at with it. But I think it is reasonable for people to have concerns that the report calls out 2-year waiting times. We've talked a lot about 2-year waiting times previously. Those times should be coming down for people with emergency needs, but will be increasing for everybody else. Coupled with, it's not just about neurodiversity, which is obviously the kind of hot topic that's come up previously, but it also talks about mental health services, waiting times in general across a number of different areas being a problem. And the point around there have been no recent admissions, but there are recently people, being supported out of this need. That means there are fewer people in there at the moment. But my concern is what's happening to everybody else, the people who have that emerging need, who can't get in the door, who are stuck, not really it's somewhere in the diagnosis pathway, and we don't know at the end whether that's going to be a yes or a no, of course, as well. It might be that they don't get the diagnosis they're expecting, and that then kind of resets the clock on what need they might even receive at all. So what happens to the people not in this report? What happens to all the people on the fringe of this report who haven't yet been diagnosed or seen or getting that ongoing support?
sorry, just for clarity, so a referral is made, are you referring to people that haven't hit any kind of list, just out in the community that haven't accessed anything?
Yeah, so you've got people who will be getting some support whilst they're in the diagnosis pathways. Different. I'm trying to generalize across services here, so it's a little bit dependent on the individual service. But you've got people who are getting a bit of support, but they're not getting the full support they would have if they had a diagnosis. But you've got people who are pre that point. They're not. They're waiting to wait, and you've also got the people who should have been admitted but aren't admitted because of capacity. What support did they get during that wait? It must be substantially different to the support they actually get from being admitted, right?
Yeah, I mean, it's multifaceted. I think there's conflating there, probably adult learning disability admissions and just general weights and ADHD and autism. So I think they're all a bit conflated there. So primary care obviously have a responsibility to support people as well with us in partnership, and also social care. So community transformation is one of our biggest priorities and where we are investing heavily, as are the ICB, our system health partners, because actually what you want to do is catch people upstream rather than wait until they get to crisis or needing a hospital bed that actually you don't have. So there's a lot of work going on around community transformation. In terms of adult learning disability, the whole point, the kind of white paper approach, if you like, is called Transforming Care, is not to admit patients with learning disability into hospital. And if you look back at previous reports, particularly around inpatients in the north of our patch, it can be really, really detrimental. So for us, we're really quite proud, even under challenge of staffing, around our ability to prevent admission into hospital of people with learning disability, even when their needs are really, really complex. And it's often one of those situations where as a lay person, for want of a better word, and sorry, that's not meant to sound derogatory, but would see the complexity and think they need to be in hospital, but actually it's the reverse. So we are in the process of developing, we have investment for an intensive home support service for our adult learning disability service users to wrap around them as part of a system and keep them out of hospital and keep them safe at home. So community transformation is where the focus is for everything, stopping people needing those crisis services and admissions. Learning disability is very unique in that we know the evidence is they shouldn't be in hospital. It's very restrictive and doesn't aid their recovery or acknowledge their trauma.
No. Sorry, just to add, and our inpatient wards for adults with learning disability are all in Durham Tees Valley, but that's not to say that if necessary that patients with a learning disability from York could not be placed in some of those beds. However, as Helen said, we try to avoid it, and we are developing that intensive support at home team. But there are also conversations happening in Durham Tees Valley between colleagues there and broader system partners, including social care, about actually how do we make changes to that current model of having inpatient beds? How do we support people better in the community so they can remain in their own homes? A lot of that is about the teams across primary care, social care and the voluntary sector who can go in and support people. But also we need adequate housing as well for people to go into. So there's a lot of conversations happening at the moment, both in Durham Tees Valley where the beds are, but also across our system as well about what that looks like. I mean, quite often the things that block somebody from getting out of hospital when they should really be moving on is access to housing and social care support. That's not to throw this at the door of social care colleagues, not at all. We just need to work together.
Yeah, and that was a good response to a scattergun trying to pick up all those challenges around it. I guess my point is that we know the need is growing from all those social needs we're talking about there. If the capacity isn't growing, in fact is shrinking, if those lists are getting longer, there's a larger number of people who are trapped without the support they need who won't be visible on this report. So the report's good. There's a lot of positives compared to where it was before. There's still room for improvement, particularly around staffing, agency training. But we need to be really conscious and obviously talking to the ICB, public health, about that other greater need that kind of sits around the periphery of this report.
Yeah, to respond, I think you've hit the nail on the head. So it's kind of moving across to our challenge around health inequalities then, rather than our provision as a secondary care provider. And obviously that agenda's huge. What I would just say as we approach the end of the agenda item is communication and social movement, etc., is key. And please don't feel that there's a boundary there. If anybody wants to come into any of our services within the best that I can do, you're welcome to come and visit or have a coffee. And, you know, if you've got a specific interest in something, please come along and have a coffee. It's not a problem.
I appreciate that, Helen. I think we may pick you up on that. Some committee members may have an interest. It'd be good to do that. I've got one more question and a real quick summary to say you did a good summary as well, Councillor Rose. But on the back of that, I think the committee must recognise the improvements made in the CQC report from previous CQC reports. So steps in the right direction. I just want to ask a question about York's access to the crisis telephone. It's highlighted in the report. It's stated as a must-do action. How do you make that a high priority? There's 38 must-dos. That seems quite a fundamental one to make sure the lines aren't constantly busy.
You'll get a joint response from us both here. I can absolutely assure the committee that that was a priority for us before CQC ever said it was a must-do action. We've managed to make some improvements already through working with voluntary sector colleagues. We diverted some money to a couple of voluntary sector organisations to add in capacity to the crisis team so that we could respond to more calls. Now, that's been really good, and it has seen an improvement for across York and North Yorkshire because it's the one shared number. And we are now seeing response rates in the 90s. However, we want to make further improvement because we're aware that when you first call, you speak to somebody in the voluntary sector, they offer support. But if you're in absolute crisis, you then pass to one of our clinicians, because although our clinicians offer training and supervision and support to the voluntary sector, we are very clear that there are some people who absolutely need to come through to us in secondary care. And those response rates are not where we need them to be. They were roughly about 40% fairly recently, so we need to drive them up. We've just been through a process of re-procurement and we've now got a new provider. We're out of the standstill period, so I can't say that it's every turn who are going to provide that voluntary sector first bit. That's going to be even better for us because we're just working with one partner there. But then, of course, Helen, I think it's April, we're doing NHS 111. So April, we'll be piloting NHS 111. That's a government initiative across the whole of England where anybody who dials 111 and selects 2, which means they want mental health support, they will be transferred to their closest local mental health provider. We will be watching that very keenly because our colleagues in Humber region who've already launched it saw a huge increase in demand. They'd been given some extra money from NHS England to get some additional staff in, but it hasn't been enough. So we will keep a close eye on that, but we scrutinise and monitor the crisis line information on a very regular basis. Unfortunately, and I feel a little bit like I'm in a loop and I just keep repeating myself. Part of the issue is until we can build up capacity in the crisis team, we're always going to have a bit of an issue, but we are working on it. Do you want to?
I think Zoe summarised nicely there, but just to add from an assurance point of view that service users don't just drop out of the loop if they're struggling to get through, they're kept in the process. And we also scrutinise data. So since we added in the voluntary sector, the option 1 for mental health support as an option, we're scrutinising a lot more data, and sometimes what we're seeing is a theme coming through, not huge numbers, but things like, well, I couldn't get an appointment somewhere, or my appointment, you know, so I'm ringing here, or a CAMS patient, so I'm ringing this line. So we're able to get a better hold on the data.
Yeah, okay. Councillor Rose on that, and I'll come to Councillor Bassey after.
Yeah, just wanted to add, I think you're absolutely right to call out that particular key finding, and I guess all the other dozens of musts are also all very critical as well. So the trust must ensure that learning from incidents, deaths and complaints is effective and embedded to reduce risk, must improve governance systems and process to identify and escalate risks, including early warning signs, must ensure it has a strategy for physical healthcare. They're pretty big all across the board. What's missing here is then the action plan off the back of it that then says how actually that's going to be dealt with. And I know we've talked already about a couple of them being, it's quite complex and knotty. That still obviously becomes an action plan at some point in due course, and I'm sure it will come back to here over the coming months. But
yeah, I mean, the action plans are, they're so big, but if you wanted to choose an aspect like physical healthcare, for example, then I'm happy to come back and go through that in detail, if you wanted to take it one by one, because obviously they're quite meaty, so happy to do that.
Okay, Councillor Vassie.
Yes, I support a lot of the comments that have been made, and I'm glad to hear the answers. I'm glad to see that there have been improvements. My first question is a general one about the data. Something that alarmed me looking at the data was how much of it was old and how limited the inspection had been. So and some of it goes back 4 years to March 2020. When we were in the eye of the pandemic. And that's the last time we've looked at community-based mental health services for older people and long-stay mental health wards for working age adults. That's the last time an inspection took place. That worries me because I think how much the world has changed since then, how much we were struggling in that period and the 4 years that have happened since. So my first question really is, how much confidence can we have in this traffic light system that shows us things are good? And when we look closely, we see in March 2020, or on page 14, we see specifically that in December 2021, Specialist Eating Disorders Service was rated as good. Then in October 23, it's been upgraded to outstanding, but the date put on it is March 2020. So I just found the detail within this lacking and concerning. And I'm just wondering how you feel about it and how urgent you think it is that all those areas are inspected again and thoroughly so that we can have confidence in the data.
Thank you. Really good question. So obviously it's difficult to influence the regime of how the CQC undergo their inspections. What they will do, and for them often it's based on capacity as well, is they will prioritise the services that they're coming to inspect. And often the reasons why they'll look at some and not another is because of other intelligence which they're receiving. So we have to send them a lot of data, qualitative, quantitative, and they'll look at, national benchmarking, the number of incidents we've had, and decide if a service needs inspecting or not, or actually whether the metrics that are measuring quality by proxy, they're happy with, and they might leave that service. I can't comment on the eating disorder one. I just need to go away and have a look at that one, because that doesn't sound quite right. In terms of data and data lag, you're absolutely right. So from the point of them preparing to come in to inspect, we have to send them a lot of data. Then to the point of coming in to inspect, and then to the point of publishing the report, and then to the point of us coming into various committees, it can be several years. So the assurance we would give you on the back of that is our own governance systems. So what we class as assurance or good quality audit data, going and having a look, all the things that assure ourselves on a day-to-day basis. But yeah, the CQC inspection regime as was certainly had a lot of pitfalls. We would have opportunity to comment on factual accuracy, so we would get given a draft of the report and the executive board would be able to action factual accuracy. But for the reasons you've just said and many others, that's why the CQC are changing their approach to their inspections. So this comprehensive report that you'll see, you probably won't see again.
Thank you. I mean, so am I right then for me to be worried when I see data from March 2020 about mental health wards for working age adults in the context of a world where we were all at home. And would you also wish to see, you know, aside from the CQC inspection, would you wish, or are you comfortable that the situation in that particular area is being managed well, is in order, and that you have data that enables you to feel comfortable beyond what was gathered 4 years ago?
Absolutely. I can't say that our services are perfect, but in terms of monitoring them and seeking assurance around quality and safety and patient experience, then yes, because we've got our own robust governance systems that are going on every hour, every day, every week, every month.
Okay, thank you. Can I move on to a couple of other things? Staffing levels and supervision has been rehearsed. There were questions in the inspection report on two other areas that I wanted to pick out. One was on leadership and management at a local level. And the report says we found effective leadership and management at a local level in most services. However, we found that some of the trust's systems and processes did not operate effectively at a senior level. This meant that whilst we rated well-led as good in most core services, we rated the trust as requires improvement for the overall well-led key question. So it seems to be, tell me if I'm misunderstanding this, that at what is sometimes called the coalface, things are being done and there is happiness that they're being well done, but at the strategic management level, there are issues that the inspection highlighted. Is that a fair assessment?
It's a fair assessment, so I might want to take this as an executive director.
Yeah, happy to. I think, no, I don't think I know that one of the biggest questions that CQC had for us as executives was actually, and this might surprise you, but was the volume of data that we were looking at on a regular basis. We have developed an internal report that's called the Integrated Performance Report, and we have them at both care group level and also at trust-wide level, and it brings together and triangulates a whole range of different data from finance and staffing data, service performance data, and our performance and planning team, they do a lot of work to analyse that following kind of the SPC process. Don't ask me exactly what SPC stands for, it's statistical something. Which tells us whether or not we have good assurance or reasonable assurance or poor assurance on particular measures. And we have these very, very large 70, 80 odd page reports that we look at on a very, very regular basis. And CQC's sense was that actually that was too much. And that we should be honing in and looking at specific measures and fewer measures. And that's exactly what we've started to do. So we've started to focus in and on some of the kind of primary key things like waiting lists, and to be poring over that information rather than having a whole range of different, I mean, we still look at the whole range. It's really just about, as you're getting up to kind of exec and board level, that it should have been well rehearsed underneath in the various groups. And then what you get is kind of your key headline findings. So there was a particular issue around that. We also had a fairly new risk management system and a fairly new head of risk management that was still embedding at the time that the inspection was taking place. So there was just a sense of that obviously there needed to be improvements there. They are happening as that's all being embedded. And Helen alluded before as well that, you know, we're moving away from an old system of recording incidents to a new system that again will actually give us better information, better data that will be richer that we can use. So all of those things weren't quite in place when CQC were inspecting us. They are in train and will be in place soon.
Thank you. It does reflect something of what the points Councillor Rose was making as well. And I think it would be good, Chair, if when we next hear from this, there was some engagement with that part of it, because this list on the actual inspection report is huge of things that need doing. We accept that it's a very complicated issue and a complicated business. But that criticism in the report about effectively managing it is seems to me is one of the keys. How do you deal with all this complexity? And the report, the summary that we got really doesn't get us into that, to understand how things can be improved and the comments that we might be able to make to help enable that to happen. There's just one last quick thing, if I may, Chair. There are so many things that need looking at, and I don't pretend to be an expert. So it's to get a sense of how you're managing this. I think that matters to me. The use of monitoring equipment is mentioned in the inspection report. It's been discussed here on scrutiny over the past 4 years. The whole relationship between supervision and consent, between civil liberties and permission and understanding. And within this report, the inspection report says the Trust must ensure that it has a clear policy relating to the use of technology to monitor patients on inpatient wards, and that this policy is accessible to patients and staff to understand the reasons for its use. And when we've looked at this before in scrutiny, this has been one of the key issues that's come up, that it's possible to put all sorts of systems in to monitor people to the benefit of the system, to the benefit of the trust, but that doesn't necessarily reflect the interests of the patient or necessarily imply and involve their consent. So I'm keen, just before I pass on, to get a sense of what's being done to deal with this, to ensure that there's proper consent and engagement.
Yeah, so since the report, it has actually been addressed through robust policy, and we've done that in several ways. One is to use our co-creation team to work with patients to get their take their opinion on it to inform the policy, because they're the ones that it's affecting. So our policy is co-created from a consent point of view. We absolutely try and achieve informed consent. So the system is called OxyVision or OxyHealth. So we explain to the patient what it's about and the benefits that it can bring. It is very, very rare that a patient says no, because if we give them enough information that it's not, spying on them in the toilet or anything. Most patients do want to be kept safe. So we do try and achieve informed consent. If we can't do that due to capacity, then obviously we're at liberty to make a best interest decision. Again, the devil is in the detail. So when we have incidents, we will look to see if OxyHealth helped us preempt or intervene in a timely manner for an incident, such as a patient starting to ligature or becoming medically, physically unwell, all manner of things. Or, they can't be seen in their room for a few seconds, and the evidence is significant of the benefit of using this particular technology. So to answer your question, we didn't have it right in terms of consent. We've worked with the company, we've worked with co-creation to get the patient voice in the policy, and hopefully we're where we need to be. But the evidence is it's a very positive thing for safety.
Thank you. Thank you, Chair.
Thank you. That's a really good question. Thank you for the answer on that one. I think that brings us to the end of the agenda item. If everybody's happy. So we're asked as a committee to note the progress made since 2021 CQC and note the actions and the progress so far on those must do and should do items, which we've picked up on. And we want to thank you both, Zoe and Helen, for coming along and giving us the answers to those queries and the report. And we will come back to you as a committee. We shall look at those actions that need doing, and we will invite you at a future date. Okay. Thank you very much.
Thank you.
Okay, members. So we'll move on to agenda item 5. We'll ask Patrick and Steve to come to the table for finance and performance monitor Q3, and Michael and Peter as well. Thank you for joining us. What page are we on? We're on page 27.
Thank you, Chair. So the report presented to the committee covers the Monitor 3 Finance and Performance Report for Health, Housing and Adult Social Care service areas. It uses extracts of data that was considered by Executive on 25th of January. So for the first time in a long time, I think we've actually got some information that's pretty much straight after the data has been considered. So the report provides members with details of the overall financial position of the council, which is showing a gross projected overspend of £6 million at this time, although there are mitigation options, use of reserves and so on and so forth, which we are projecting will bring it back into balance. But I think you'll all be aware that the council is under significant financial pressure. There's a continuing trend of pressures that we're facing, with particularly across adult social care, where demand is increasing, as well as the complexity and cost of care. So it is a very serious issue, which we're more than keen for members of the Scrutiny Committee to consider and to challenge and to give your views on those. So something I'd highlight to the committee is that historically we've seen overspends reducing through the year. So we'd have a big overspend at Monitor 1, that would reduce at Monitor 2 and be lower at Monitor 3. That just hasn't happened this year. It's been staying at these high levels throughout the year. So one thing that was considered as part of last week's executive, and it will be going forward to Budget Council next month, is we are looking at adding an extra £4 million of growth into the council budget. Unfortunately, that comes with a requirement to make additional £4 million worth of savings, and those have been incorporated. So the £4 million would probably, the majority of it would go into adult social care, given the ongoing pressures that we've been seeing in here. From paragraph 13, you'll see more detailed analysis of the financial position. Most of the narrative is in adult social care because that's the biggest area of the spend, but there is also some paragraphs on housing and public health. From paragraph 55, the business intelligence team have identified the performance scorecards relating to the new council plan. The full set of indicators across the scrutiny remit are provided at Annex 1. So it's really for you to consider the report, ask questions for officers around the table. Apologies, we haven't got any housing operations officers, so if there are any particular questions around housing operations, I will have to take those and pass them on to relevant colleagues tomorrow.
I appreciate that, Patrick. Thank you for the report. It is very timely for members, so I appreciate we've dropped on nicely. I'll start with an even more timely one, and to ask if you know the answer yet to, I think it's this week's announcement by the government that there's an extra 500 million earmarked for future adult social care and children's social care services being divided up amongst local authorities. I think the expectation being April for delivery of that funding. Do you know if that's the case and what size and how York is factored into that? And confirm that it's not going to help the in-year pressures that we've got presently.
There is an announcement of an additional 500 million across local authorities. I think actually it was 600 million, 500 for adult social care, which will be incorporated into the adult social care grant. That will be confirmed in the final settlement information, which we're expecting in early March. So we don't currently know exactly how much we're going to get. We can make an assessment based on the proportion of grant that we've historically received. So it's likely to be over £1 million, but the detail and the terms that might come with it, we're not clear on just yet.
Okay, thank you for that. Members, I open it out for questions and comments. I'll take Councillor Baxter first and we'll go to Councillor.
Thank you, Chair. You said that you tend to see that the spending comes down in the third monitor, but that hasn't happened so far. Do you think there's a particular reason for that, or just general spending across the country? It's not sort of specific to York.
I'll start but pass on to Michael as well. I think that it's partly because of the additional costs that have come through. Inflation has been significant over the last 2 years. We had inflation of 10% this time last year. The funding that we've received has not matched the amount of inflation. Going back to the budget that was agreed in February 2023, energy prices, I think gas prices went up by 400%. We weren't able to incorporate those increases within the budget. So we have less wriggle room that we've had previously that we've been able to do offsetting savings. So the continued price and cost pressures have been continuing, and as I say, there's just less opportunity to make underspends in other areas that will offset that. Again, I think looking across local authorities across the sector, we'll see a number of local authorities, and everyone I hear is talking about similar requirements to make ongoing cuts to services.
I just add, I think there's been quite a lot of one-off funding at the year end as well. Last couple of years we've had significant health funding throughout the year and coming at the year end. Last year in adult social care we used 1.5 million of a reserve from the Better Care Fund to support our position. So there's been quite a few bits and pieces like that at year end that's probably masked the underlying situation.
Thank you. Councillor Rose.
Yeah, I've got 3 separate questions, but piggybacking off that one for my first one, I guess obviously the big picture across the whole council, we're looking at finance. I know this isn't a finance scrutiny, so I won't ask too much about it, but how can we be confident going into next year when this is one of the primary drivers of some of the major cuts we're having to make that gets all the bad press and that nobody really wants to see across the city? That massive spike in extra costs this financial year that then hasn't come down as much. How was that not baked into the budget at the start of last year? How can we be confident that this year the budget is already fit for purpose at the point we enter the year, and we're not going to immediately suddenly see an overspend of 10 million pounds across the council? How does that work from a sort of scrutinising the numbers perspective from your side?
Well, when we the budget is considered by members each year. It's based on the information that we have at the time that those numbers go through. So when the budget was set in February 2023, based on all things being considered, it was deemed to be a prudent budget. But the levels of inflation have been higher for longer than was assumed, and a number of those assumptions that were made at that particular point in time haven't come to fruition, and therefore that's why we've been on the back foot this year in terms of having to find mitigating savings. Let's say certainly utility prices was just one example of where those costs were significant, and then suppliers across all the services we provide were coming back with higher than inflation or inflationary increased demands, because they were facing increased cost of staffing, increased costs of premises, and so on and so forth. So what we have done for this financial year and the budget that's being proposed, as I say, we have put additional savings in. Back in November, we were forecasting £40 million savings would be required over 4 years. We've increased the levels of savings that we believe the authority needs, and it will still be a challenging position next year, but if those savings can be delivered, well, we feel that we've got a robust budget for next financial year. But again, members will be considering that next month at Budget Council. I don't want to preempt what members will be.
I think the other thing to consider is other things that are happening in the market. I think there's other things happening as well that people need to be aware of. So in order to drive through the savings and efficiencies that are needed, obviously the social work resource to do that has been diverted considerably over the last year in terms of provider failure and issues in the hospital and getting that situated, getting people in, using a lot of agency staff. So it's not just the cost of things, it's the capacity to drive through the efficiencies, because in adult social care, the underlying position has been broadly the same from Q1 to Q2 to Q3. It's that driving out the efficiencies and the savings, not just this year, the ones from previous years, that we need to get that capacity and to drive through. So that's one of the reasons for it.
Thank you for that. Do you want to continue,
Yeah,
councillor?
just to follow up the same point, I'm happy for you to spread my questions. But yes, so at this point last year, obviously, we knew there was high inflation. So part of it was that we had assumed it would taper off more than it did in reality. A supplier's catching up a couple of years of very high inflation costs. How confident are we going into this year that we're likely that there isn't as much risk, that things are going to change for the worse over the course of that year, that suppliers aren't going to be backdating increasing costs well above inflationary levels? Like, what are your thoughts about that at the moment?
As I say, that was one of the drivers for putting an additional £4 million into the budget, and to specifically allocate that into social care, which is an area where for the past few years we've been saying that we need to drive offsetting efficiencies to get back into the budget. I think there's a recognition now that that will not be possible to do. So we need to add the money into that budget so that they can start up on a much better footing than they have done previously. It's still going to be tight. There's still going to be pressures. Inflation is coming down at a rate quicker than the Bank of England had been assuming. There's forecasts that that might be dropping down to 2%, or their forecast by May or June. But there's a lot of macroeconomic impact. What will happen with interest rates, how the council actually drives through some of the savings that it needs to do. So no promises for next year, because it's going to still be very, very difficult and very challenging for the departments. But we're, let's say, we believe that the budget that's being set is a robust budget.
Yeah, I would, just echo what Patrick's saying there. It's a very challenging position, but to reassure members that in year a number of things have been put in place in adult social care around, particularly around the way in which we contract with the independent sector, to make sure that the frameworks are in place, that we get the right price, both in terms of residential and nursing care and care at home. And also that our staff are able to pull on those resources and get the right support at the right price through the introduction of things like brokerage. But that has to be balanced by having, a sustainable and safe and quality market. And obviously, we need providers who are sustainable. And Steve referred to some of the market, failure that we've had over recent time as well. So there's a balance that needs to be struck between being as efficient as we can be, a large amount of our spend being in the independent sector, and being able to sustain that so that we have good quality provision, which we're able to draw upon. And there's other things which are happening, and I think at the last scrutiny, you heard about the reprocurement of our reablement service. So a number of things which we're putting in place to try and ensure that the models of support that we have are those which sustain independence and create more independence for people, rather than necessarily simply look after them. But that's not to say that we aren't going to have an extremely challenging year next year as well.
Thank you for that, Michael. I agree. We did have a good session on reablement, and provided a lot of assurance to committee in November, I think. So I'm going to move to Councillor Vassie and then take any more after that.
Thank you, Chair. My first comment is about the data and the way it's presented. I noted that nearly 3/4 of the statistics, the performance indicators, say there are no benchmarks available. And that surprised me a little. I can see that it relates to ward data, but no absolute gaps in mortality ratios from circulatory disease. I would imagine that is of interest in lots of local authorities, and there is national data on the gaps. Why are there no benchmarks next to all of this to help us contextualize the information?
I'll pick that up, Chair, if I may. Thanks, Councillor Vassie, for the comments. And it's a little bit of a I'll get back to you answer, which is that I'm looking down at some of this, and I myself I'm thinking, I'm pretty sure we can find national comparators for these. Not all of them, and you're absolutely right. Where we're choosing an approach to differences between wards, there are some of these where I think that taking that approach locally in York helps us answer the questions around inequalities, but it means it comparing, for instance, wards are all different sizes, so making those sort of comparisons might not be possible. But there are some of these within the tracker I think we could find a benchmark for, and I'll take that back, and we'll try to make sure that in future versions of this we have, where a benchmark is available and it's easy to pull that from national data sets, for instance, we make sure it's within the table.
Thank you. I think that would be helpful going forwards, because for us as politicians with only an amateur understanding of it, those benchmarks are hugely helpful in helping us understand context.
Chair, if I could, the only thing I'd add to that is a lot of these are from the new council plan that was agreed from the autumn time. So for the business intelligence team, it's a case of pulling together lots of new data sources and new information, and it is going to take a bit of time to get some of the data that Peter rightly points out, and work with colleagues to sort of see where it is the best way of getting this comparable information, so we can do that. But it is going to be a bit of work in progress and moving forward on that.
Yeah, thank you for that, Patrick.
Okay.
Of
Yes.
course, Councillor Vassie, carry on.
Thank you. To get into the stuff of the data, obviously there's some good news, there's some bad news. We see this every time, and we have to try and make sense of where the holdups are and what can be done to deal with them. One thing that leapt out of me, because it's been a concern to this committee for the past months, is the significant increase in rough sleepers over the winter. And given the context of our discussions at previous meetings, can you give me an indication of how many of these individuals may be banned from entering council premises? We have these kind of discussions about the changing services, our concerns about how people might slip through the net. And given that we've had this increase, it would be good to get an understanding of whether there has been an increase in people who can't get help, or whether we're coping with this situation, how we're dealing with it.
So we haven't got anybody here this evening from housing, but I'm very happy to take that question back and see what we can do in terms of those figures around the issues which are preventing people from accessing the support which they clearly need.
That's good to hear. Sorry, Chair. Just if we could add then, because you've pointed out there's no housing person here, and I understand the increase in the number of voids, I think we'd also probably be useful to get information on. And a completely different thing, and then I'll shut up if that's okay. Sorry.
Thank you, Councillor Vassie. I'll bring Councillor Steelswell in, who's wanting a supplementary on that issue.
Yeah, it was just a supplementary around the increase in rough sleepers, and I know you probably won't be able to answer it because there's no one from housing, but also to follow on from that, I wanted to know if all the NOSNO beds were actually full, if these people were able in some way to access them, and if the people who, the increase in rough sleepers, if these people have been engaged with and asked them what the barriers were to entering any, being able to access these NOSNO beds, and if indeed they were people who were able to at all, so they had a local connection and things. Thank you.
Yeah, I'm happy to take that back and get an answer for you.
Okay, thank you. And for the public, NOSNO, no second night out beds. Yep. Okay. Thank you, Councillor Steelswell. I'd be very happy to invite the executive member for housing to the table, if he did want to provide any comment or response on those issues. And whilst I'm speaking and we've got this discussion live, I'd also like to place on record and maybe for officers to take back for an answer would be around the navigators. I've forgotten where it's referred to now, but it talks about the navigators. Page 5. I've missed my notes, but basically there are more navigators now than what there were previously to engaged with rough sleepers, but the data shows an increasing number of rough sleepers, and I just wondered if there was a possibility that there could be more early morning walks, because there's significantly more staff on the establishment in this sector, and I feel that that would have a positive impact. So if that one could just be taken away, and I'm going to bring in the executive member for housing, Councillor Pavlovic.
Thank you, Chair. Michael Pavlovic, Councillor Pavlovic, exec member for housing and planning. I didn't catch all of Councillor Vassey's earlier question. So if you want to repeat that, I will answer it if I possibly can. In respect of No Second Night Out, my understanding is that all the emergency beds and all the No Second Night Out beds and the severe weather provision beds are pretty much full pretty much all of the time. Certainly the last time I was asking, that all beds, including mattresses, and any sort of crash pad type, were full over the bad weather in particular. In respect of the increasing numbers of rough sleepers, I think what you're actually seeing now is a more accurate reflection of the rough sleeper numbers that I think we all suspected was the case, and it's why I've insisted that our rough sleeper numbers are made publicly available on a quarterly basis, instead of using the figures from the previous November and expecting that to be the accurate figure throughout the rest of that year. But could there be more early morning walks? I think the fact that you've got a significant, I would argue, accurate representation of the rough sleeper numbers is an indicator of the counts that are already happening. It may be that there are more identified on a particular morning, but the rough sleeper count is basically the people that the navigators who are now doing the count are aware of. It's not necessarily on one overnight count. I think there was a question about voids as well. I'm happy to answer that, but do you have a supplementary about rough sleepers?
No, but Councillor Vassey's point was about people banned from council service or engaging with council staff. Did you want to repeat that?
Yes, thank you, Chair. When we met in November, the Salvation Army expressed concerns that certain rough sleepers might not be able to avail themselves of help from the council because they had been banned by the council for a variety of reasons. Some had, complex lives and needs and were disruptive. And there was a fear that there was a core of people who might find themselves with no access to help. So the question was, really, has that happened? Are there individuals who are struggling to get any form of help at the moment? Is there evidence that the council is able to help everyone?
Everybody is engaged with, whether they've been excluded from a particular hostel, for example. The services will continue to work with them to try to get them to re-engage, to go back into services. So that is always available, always has been. The work that the Salvation Army were doing was incredibly valuable, but it was just a way of trying to get people back into services. The navigators are now trying to get those people back into services. And that's not to negate the work that the Salvation Army did, of course, Christian.
Okay, and whilst you're here, we'll turn to the voids question
Yeah.
if you did want to answer that, and then we'll move back onto our agenda item.
Sure. So voids have been going down. There's been a significant focus on reducing voids for a variety of reasons. The housing waiting list, the need to get revenue coming in. The reason it's gone up is that for 2 months we had an abnormally large number of voids becoming available. So normally in a normal given month we would have between 8 and 10 voids per month becoming available. In September there were 24 came available. Talking with officers, there's no rhyme or reason to it. A lot of people sadly died in that month that were council tenants, and that their properties became available. We've had a similar spike in January. So this last month there's been a similar spike, and so that does create a change to the normal peak and flow of the voids, but we are putting additional resources into trying to clear the voids as far as we can.
Yeah. Okay, thank you. Councillor Smalley.
Thank you very much, Chair. I think, generally it doesn't sort of make very pleasant reading. And I think, generally, obviously, local government in a very, very perilous state at the moment, and many councils are in a similar position, although some are faring slightly better and some slightly worse. I think looking at, in particular, the growth and overspends in social care, and I think Councillor Rose's point earlier about how every year, the last administration, probably the administration before that, possibly the administration before that, we've put in growth. There's always been growth in this area, at least for my period on the council. And that doesn't ever sort of solve the problem, in the sense that there's then overspends on top of that. I think on housing, it would be, we only do this once a year. There's significant notice, and when we're discussing this, it would be quite good to have an officer present. I guess, just my view, Chair, but I think this committee, from the delayed reports into homelessness to not having an officer present here isn't particularly being massively well served. And how it's always fantastic to have Councillor Pavlovich here, and I'm not saying he might varnish any of his answers, but I think it is usually quite helpful to hear it from the horse's mouth in terms of the people on the front line doing the work. So I think it would be great if we could have officers here in 2025 when we're sat here discussing this again. And my actual question is about on page 33, paragraph 26 talks about how the following sections describe the variations to budgeted costs, customer number and income. The variations are generally due to not fully meeting previous year's savings targets, plus significant price pressures in the market. I guess this expands upon what Councillor Rose was saying, in the sense that we then have a lot of information about direct payments, home and day support, supported living, where almost all the explanations are explained by a higher cost than budgeted. So I guess my question is twofold. One, given that we knew inflation was high this time last year, I guess why was that budgeting so wrong in so many places? Why was the cost per placement or the number predicted of people that might be using that service is so different compared to the budget? And what, as managers, are you doing to? And then the second part is, where we've not met that saving, I guess that isn't really described in any of those paragraphs in any detail. And what, as I guess senior managers, if your service manager doesn't meet that saving, what conversations are being had at the moment to try and ensure that does happen? Because we are going to be sat here in January 2025 with exactly the same report if the savings that the administration are currently proposing aren't met.
Okay, so thanks for that, Councillor Smiley. I'll jump in and get your first comment answered around housing officers, and I'd say it's maybe a miscommunication on our part as a committee or mine as chair to say that we're trying to split the topics at each meeting, because we're meeting more per year than what we used to, and we're trying to chunk it up. So the finance and performance coming to this committee relatively very early since it's been published has meant that until that point there's no housing items on the agenda. So whilst I take your point, we can change the way we do this when we get to the work plan agenda item, and I'd be happy to hear the committee's views, because some months it hasn't worked, you're quite right, but some months it seems to work better where we're not scattergunning right across the directorate. So that's just the answer from the chair to that, and then I'll pass over to officers for your other points.
In terms of rebasing the budget, it is because of previous non-achieved savings from previous years, and the growth that we've got has broadly gone against inflationary increases. So if you think about last year or this current year, you get significant growth, but we've just undergone a cost of care exercise where we significantly increased the rate we pay to home care providers, residential providers, nursing providers, supported living providers. So in general, I would say the growth that we've had over the past year has kept pace to some extent with those price increases. In order to afford that growth, there's all the savings that were listed, and it's quite difficult to try and explain it more reasonably to people in a public document, because one thing we have to be wary of is giving away our competitive advantage when we're talking about the prices. I don't think there's any way I could circulate something outside of this meeting that was confidential about how we set the budgets in terms of customer numbers, because we do an exercise, if we can and are able to, around February each year, looking at our customer numbers, not just on like expenditure lines. We look at every single line within the ledger, particularly around external care, what we might expect in terms of continuing healthcare, customer income. So we do a very detailed job of trying to guess what it's going to cost in the future years. So I think when we look at the next financial year, we will be bringing back those options where we haven't delivered on previous year's savings as a way of saying, right, what can we deliver? As we progress through the year, we have had several financial recovery plans, series of mitigations where we've recognised that some of the things we're not able to do for whatever reason. I think a lot of it has been around workforce and be able to drive through those things in the past, which I mentioned earlier. And we're also probably paying a bit for COVID, and when we got people out of hospital very quickly, not necessarily to the right place, probably to a more expensive place than we anticipated. And so we've got that built into our budgets where we're trying to address by, as Michael, the director alluded to earlier, we've introduced frameworks in all the big spend areas in terms of adult social care. So I'm not sure if I'm answered your question, but I think the fact that we haven't delivered some of these savings, Michael might be able to expand on why that's been the case, but they'll certainly be back on the table now in terms of what we need to do to make sure that we meet our budget next year.
So yeah, I mean, there are a number of reasons why I think it's been extremely challenging. As Steve said, the growth's largely been eaten up by inflation, which has meant that effectively we've had to either prevent people from coming into service or reduce the amount of service which people have, or the length of time which people then have that service. I think we've done as good a job as we can on cost, but things are costing an awful lot more. And when you have a workforce, which, again, I say we've done a good job this year in moving towards a much stable workforce, a lot less agency work, but a lot of the work has been around firefighting, around things like provider failure, and around managing some of the more difficult elements which we've had to deal with in year. And as we get through working with individuals around trying to reduce the amount of care we have, or the length of time we put that in, those are difficult conversations which have to happen through social work, occupational therapy, those types of approaches. And I'm confident that we're getting in a much better place. We have a new practice model which we've refreshed and are implementing, and then greater assurance in the system. So throughout the year, we've worked with our finance colleagues around putting in assurance processes around the cost of individual packages, and in making sure that at an operational level there is a challenge through a joint operational finance meeting with heads of service, where all of those spends, financial recovery plans are challenged and driven forward. I think these are times when I talk to other colleagues around the region, it's very, very similar kinds of positions. The room which we've got to make savings continues to shrink, and the inflationary pressures this year have continued to increase. So I think, the going forward in terms of the confidence around the budget next year, we've put forward things which we think we are confident in terms of being able to deliver, but they are extremely difficult and painful in terms of the impact which they have both on people and the ability of our staff to deliver. And I wouldn't want to sugarcoat that any more than than it is. That is the position which we're in.
Yep.
Yeah, just really quickly, I guess that makes sense and roughly what I was, expecting. I think this happened the whole 4 years of the last administration. Adults is facing immense pressure, and this team's doing amazing work, but nonetheless, through growth every year and failure to achieve savings, it takes a lot of money out of other areas of the council, which means that by about 2040, the council will essentially be an elected social care agency, and there'll be no room to do anything else. Hopefully there's settlements that stop that happening, but that's basically the trajectory without significant change. I guess my question is, do sort of those service managers, in terms of the savings targets you've got now, and you've talked about your confidence or not in terms of achieving them throughout 2024 and early 2025, I guess, how do they feel ownership of those sort of savings targets? Say you make a saving in libraries, for instance, just to take a random example, the service manager there will feel ultimately incredibly responsible for achieving that. I guess, does that translate against your realm, Michael, because it is such large sums that we're talking about?
So I'd say yes. So there's a huge amount of the conversation which happens, which is about the financial risk, and that falls into the issues which you talked about. There is an inequalities element to this, which people are really, really conscious of, that we need to make sure that we get absolutely the value that we are seeking from our interventions, because if we are over providing to one person, we're likely to be under providing to another. The staff which we have in the management are extremely conscientious and mindful of the decisions which we're making around finance, and the level of detail around the thresholds of care and the amount of care which we put in, and how that impacts on the budget, and balancing that against our statutory duties is constantly on the mind of the staff who are working in the service.
And to back that up, finance will go around all the social. It is on. Just to back that up, finance are going around all the social work teams, giving a presentation on not just the adult social care finance position, the council finance position, alluding to health position as well, and really hammering home the importance of being careful with every pound we spend. So we're doing a tour at the minute. If you want tickets, I'll patch you in.
Okay, Councillor Rose.
Yeah, just on all that point, I mean, one very slight correction on that, long before 2040, we go bankrupt as a council if we progress on that journey. But I agree with all those points made, and I had the same section of points 25 through 37 highlighted. Not intending to try and coax Joe out from the back of the room, but this might be more adult social care than BI or finance. There's lots of things in here that are relatively vague in terms of what they mean, because they're sort of bucketed into the 4 buckets that are in section 25. So obviously it's a little more clear what physical and sensory impairment might mean. There's a bit of detail around what older customers with mobility issues, etc. are. But poor mental health and then everything else is learning difficulty feels like a really big bucket of stuff. And when we're trying to work out what's growing and the causes behind that, and the increase in costs, looking down the list of learning disability direct payments, learning disability supported living budget, community support budgets, all these different bits and pieces. What things are included in learning disability? What things aren't included? Does everything get bucketed that's not a physical impairment into one of those 2 buckets of mental health or learning disability? Because I think most people I know with those kinds of complex needs probably wouldn't put themselves in either of those 2 categories.
So what those headlines mean are that it's anybody who's been assessed by the social work teams as having an eligible need under the Care Act, whose primary need is either mental health or learning disability. Doesn't necessarily mean that they don't have other it's a way of describing that in terms of the eligibility for social care. And then within that, depending on the setting in which somebody's in, so if somebody's living at home with a learning disability, then it will be the learning disability community support budget. And that then covers the eligible needs which we need to commission support from the market for in terms of how that person is supported at home. And likewise, if somebody's in a supported living scheme, it's about their primary need is determined under the Mental Health Act, which then gets assigned to that particular budget. And it's about the setting which they're in. And those settings, Abid will be on later talking about the commissioning strategy. And so having an eye on the different ways in which we want to support people to live their lives, around trying to reduce the amount which we spend around residential and nursing care, and looking at that particularly around people who of a working age, who we don't want to spend very much time in there at all, and helping people to live in the community more independently. That then comes into our commissioning strategy around making sure that there are enough elements of good quality, safe provision at the right kind of price in the market to achieve that. I hope that helps to answer it a little bit.
Yeah, I think that was helpful. And I guess 2 points from me on why I think it matters. The first point is about the wording and phrasing. I get a lot of it comes from statutory wording and perhaps in some cases quite old or archaic wording that hasn't been updated yet. And I think there is perhaps a lack of accuracy sometimes, or a stigma attached to certain bits of it. And I think there's something to look at in general in there and how we name things across the board. But the second one is the level of detail inside these reports, and having a £2 million overspend in something that's just one big ethereal net might be, if there's ways of categorizing within that to say, actually the growth was in this area, not this area, particularly when we talk about growth in need, not in growth and inflation. This is an area where we're seeing an increased need year on year. At the moment, it's just there's need and the need is growing, but being able to actually scrutinise that in much detail is quite difficult. So that was kind of where I was coming from on that.
Okay, thank you, councillor. I've got a couple of questions. I've got a lot of questions, but I'll stick to two, and I've got a plan which I'll discuss with members when we get to the work plan item, so I can scratch out quite a lot of what I wanted to ask. I wanted to ask you, however, on paragraph 22, so it's page 32, external care, block contracts of beds and hours at a set rate. Just a general question around the council used to have its own beds, a lot of beds that it could that it had on the books. What's the status now of the council's own beds? Are we at zero, or a general mark from you on that? And are we at greater risk now than in previous years when we had more beds, with market rate just increasing beyond either what we might have expected and factored in? And yeah, I guess a general answer on the trickiness of that situation and what could be done about it. Does the council block purchase a lot of beds and then some of them aren't used? So, you know, in terms of value for money and efficiencies, how do we manage that whole area when we've got, in my view, less control of it, because we don't have beds? And then my second question's totally different, but I'll say it while I'm there, so we don't just have to and fro. This one's for Peter, I think. On page 52, the measure HV02 for face-to-face new birth visits, it just seems incredibly low as a figure, and I'd just like some background on why that is. You know, less than a quarter of new birth visits are undertaken within the first 14 days. That's measure HV2 on page 52. So my first one about beds and the purchasing of them, and then over to Peter for that measure, if possible.
So yes, so in terms of beds, we're not a provider of residential care anymore. So everything is purchased from the independent sector. Where we've been in arrangements over the recent year where we've had to spot purchase, we haven't necessarily got the best value which we can. So block is providing better value for us. In terms of the access to beds, we have we have constant monitoring of the use of those blocks. Some of them are temporary, around supporting people and then helping people to get home. And the flow through those beds is really as important as whether they're full or not, because that's the measure of our success. And where we have block contracts where there is not the sufficient flow into them and we have vacancy, then the contracts team are on that very, very quickly. And also there is a mechanism by which, if we're not filling them, we can recoup from the contract, so that we're not paying the cost of what we're clearly not being provided with.
And just quickly on that, just to finish that point, is the cost of it just maybe out of normal projections, like everything else because of inflation? Is that in line with the cost increases that we've seen across the board in adult social care, or is there a spike because it's a really essential part of adult social care and discharge from hospital, etc.? Are we being able to ransom over and above just what could be projected fees?
I think one thing that we didn't mention is mitigating this is the investment in our independent living communities. So we've created an extra 50 beds or something in those communities. They're probably not utilised as well as they could be. And certainly there's work going on at Glen Lodge at the minute, which is restricting our ability to use those. So that's one of the ways we would seek to mitigate and manage the market, by using alternatives to residential care. In terms of the price, so if it's not on here, but the unit cost we pay for residential care has come down slightly from the start of the year due to the frameworks that we've put in place for residential and nursing care. So we've been able to get beds at our framework price, whereas previously weren't. So it's not necessarily we've got block beds, but what we have got is framework prices that resident nursing providers are willing to accept, that home care providers are willing to accept, and supported living providers are willing to accept. So that's other ways that we've managed the cost. It's still quite high in York, I would suggest, to regional and our comparator authorities, but there's some of the ways that we're mitigating.
Thank you. I appreciate that. Oh,
Yeah,
Mike.
just very briefly. So a lot of work's also been done in home care to fix a price that we think is sustainable. So we're not then in positions around frequent provider failure, or that is still a considerable risk. But also to bring people off exception providers. So where we have, we've had people supported by people who aren't on our framework. Considerable amount of work has been done by the teams working with our commissioning colleagues to make sure that those people come off those exception frameworks and come on to a reasonably priced provision. And again, that's been relatively successful. But all of these things need to come together in order to make sure that we have a more sustainable position going forward.
Thank you for that. Peter, on the other point, be useful.
Thank you. Yes, thanks, Chair. So HVO1 and O2 are complementary indicators because they are the flip side of one another, and essentially it is about timely visits for new births at 14 days. So what you're seeing with HVO2 is an improving performance position, because a couple of years ago we were getting on for 1 in 3 of our children not seen at the 14-day window, and we're now to just over 1 in 10. So that's the flip of HVO1, which is the number who are seen before 14 days. So we're pleased with that direction of travel. I think just the context there is that because the Healthy Child Service, like all public services, has had that, I guess, resource and financial challenge over the years, but probably just because as well about good practice within 0 to 19 services, not all births and some pathways are exactly the same. There are some pathways for new births where the family has particular safeguarding concerns or risks or worries around the child's health, and will be in quicker. Generally, the practice is that with first babies, you take a bit more of a proactive approach, and the support is a little more wraparound than it might be for second, third, and beyond children. So in general, the 14 days is an accepted sort of industry standard within that. I think this doesn't include, and it's a previous comments on other parts of the report, national benchmarks, but actually on all 5 of the mandatory visits, we do benchmark better than the England average in terms of timeliness. So I'm not overly concerned, because I think, to be honest, if we were in there with 100%, there would be other things we could be doing with that capacity and time, which we should be doing. So it feels an appropriate level of service delivery from my perspective.
Yeah, I appreciate you clarifying that. I've read that second HV02 incorrectly, so you've put us right on that one, and outlined direction of travel is in a good position, so thank you. Okay, Councillor Rose, and we should then make some moves to the next agenda item.
It is a relatively quick one, because I'm going to cut out my comments around 11 affordable homes in 1 year and 34% dissatisfied with the council, and focus on another public health couple of KPIs, which are specifically around 2020 versus 21-22. The gap in life expectancy growth from 8.2 years difference between the highest and lowest York wards to 11.1 years life expectancy difference, and 11.7 years for men between 2020 and then 2021. Now we know the reason for that. Ditto with the statistic further down for HIV late diagnosis going up from 81% to 86%, with it handily says up is bad next to it. But obviously there's a huge lag in when we're getting this information, and it may well have information that's still 2 years out of date. That ongoing challenge around the immediate impact of the pandemic flowing through into where we're at today, the impact on life expectancy, the impact on things like late detection of major illnesses and other work that we can do better with. What are we seeing in terms of how that's looking in reality, and is there more that we can do in terms of that number-based evidence without waiting 2 years to see where we're at now?
Thanks, Councillor Morris. So the statistics that we look at in terms of life expectancy are generally pulled from national data sources from the ONS. However, obviously, as a local authority, we collect deaths data because we register all deaths. So we do keep an internal eye, particularly on sort of death rates, particularly looking at winter and excess deaths and things like that, and summer excess deaths from extreme heat. So we look at deaths within the city internally on quite a timely basis. But when it comes to the publication of the death, and particularly not all deaths are equal, some in terms of cause will have to go through the coronial process. So there will be things that can take quite a lot of time, which I think is why the ONS publishes with a bit of a time lag. Certainly as Director of Public Health, but concerned about the general trends both in life expectancy and healthy life expectancy, where things did stall in terms of improvement within the last decade or so, and have started to go into reverse. Particularly would note the female life expectancy is not shown the improvement, and has probably gone into reverse quicker than male life expectancy. So concerned about those trends. I think there are a number of factors there. And the point about HIV late diagnosis is an important one to clarify a little bit on the figures there. As treatment for HIV has progressed, and as we find that the level of transmission that can happen when you are on some of the new antiretrovirals is virtually zero. In fact, we do say, essentially, if you're treated correctly on retroviral medication, your risk of transmission is virtually nil. It does mean that the numbers of people diagnosed with HIV in New York very happily goes down every year, and we are talking now in single figures. It does mean that sometimes when you get to that, I guess, it's not the end stage in any way, but it is when you get to the smaller numbers in an area, you find people coming forward that little bit later. Probably, to be perfectly frank, clinicians 10 to 15 years ago were more likely to pick on HIV as a potential diagnosis for a range of symptoms. We're just not seeing it that much anymore. So a late diagnosis is counted as having a CD4 cell count of below 350. So essentially, it is a clinical measure of your markers for HIV, and that 80% that was mentioned in the report is essentially, I can't remember the exact figures, but it's maybe 6 out of 7 or something like that were late diagnosis. So our emphasis in our sexual health services is encouraging people to do all the protective measures that we would have around HIV. Obviously, use of condoms and other contraceptives that prevent transmission are really important. PrEP has come on recently, which is a fantastic way, essentially, of pre and exposure to HIV, protecting yourself, and a medication that can be taken. So there are lots of things that we are doing. We are concerned about the indicator, but I probably would just caution around the small numbers. Essentially, you're getting to the difficult end of a historic problem, but the general trend is good because the numbers are going down.
Thank you for that. Okay, thank you, members. We are asked to note the report, and we can do that, and also thank officers for the updates around it and your time this evening. It's welcome that we received the finance and performance in such good time, so we can have a good discussion about it. So what I'm going to do next, We've gone 2 hours. We should do a 5-minute break. Apologies if that's not what people were hoping for, but we've got two more items before work plan, and I'd prefer us to just have a short comfort break and then we'll come back. 5 minutes. Okay. Thank you. Okay, we're good to go. So, welcome back, members. Turning now to agenda item 6, which is Adult Social Care CQC Assurance Update. Michael, are you going to talk us through that one, please?
Yes, so yes, this report is yes, so this report gives the committee an update around the CQC assurance process and the preparations which are happening within the council for when they arrive here. As members will see from the paper, for a number of years, the adult social care function of the council has not been regulated in the same way in which children's services or the NHS has. And essentially, we've operated a system with peers around improvements. You know, there's a real sense that there is something welcome about having a national framework, which then is able to make some judgments about how well local authorities are doing in terms of the way in which we serve some of our most vulnerable customers. So the framework is now agreed. We've had a number of local authorities, 5, who have gone through that pilot process. And we're now at a stage whereby we're having small numbers of local authorities who are now being put into the system, and they generally come out on a Wednesday afternoon. So we all scan our email very diligently to see if we're on the list. In terms of the approach which CQC are taking, again, it's quite different. It's quite welcome. There's a real focus on not just kind of outcomes and outputs, but the experience which people have in adult social care and what that means for them and how they feel about that. You'll see from the paper that there's the themes which the framework focuses on. So there's working with people, which is very much about what people's experience of adult social care is. The theme which is about providing support, and that touches on some of the discussions which we've had this evening about what is it that we have out there in the market which enables people to live better lives, and how do we work with our partners in terms of making sure that those things provide the right kind of support in the system. There's the theme which is around ensuring safety, and that's making sure that we have safe systems in place so that we're able to ensure that the support which is provided for people is of good quality and is safe. But it also has a focus around preparation for adulthood, so that transition from children to adults, and also that we have the right systems in place around safeguarding so that we're able to work in that multi-agency way to protect people from abuse and neglect. The judgments which are passed are largely be familiar in terms of inadequate, requires improvement, good, and outstanding. They largely follow the way in which CQC approach that for provider organisations and the NHS. In terms of the progress which we've made, so the work which we've done on this is we've been doing some work with our self-assessment, and we've been working with partners in the region on that. And we're part of that group which does some peer work in terms of looking at how well we're preparing for that. There's some really key documents which the CQC will look at, and we have a number of those which we have relatively recently refreshed and which are out there to be looked at by the public and internally. We have some which aren't necessarily there yet, and so some of the work which we need to do is around making sure that, for example, we have an up-to-date local account, which is a bit of a look backwards at what we've achieved, which tells our story, and also that we make sure that, as well as the adult social care vision, that forms into a strategy which is public-facing. And that work on that is underway, and that will appear very shortly in the public domain. And I believe we're at scrutiny shortly around the adult social care strategy. And I think, as I mentioned before, in terms of making sure that we have that refreshed practice model for social work, and we have the quality assurance framework that wraps around that to make sure that the decisions which we're making are good decisions, and that they are led by what the people tell us they want. There's been a lot of work which has happened in terms of the staff group. So we've had a series of workshops, as you can see there, whereby people have contributed both to the work in terms of our self-assessment, but also opportunities for people to talk to us about the experience which they're likely to have when CQC come to inspect, and to prepare them for those conversations. You'll see there that there is still plenty of work to be done in terms of, I would say, particularly there's a focus around co-production, engagement, and making sure that we're able to demonstrate that the actions which we take are informed by the feedback and the voice which we get from the people who we serve. So certainly more work to do on that. We've invested in a particular post to help us to make sure that the work on that increases in pace. And we are obviously in close contact with those organisations, those local authorities who've been through the process recently, in terms of the learning from that and how we can make sure that helps us prepare well for when that inspection comes.
Thank you, Michael. Really appreciate the running through of that report. It gives me a lot of assurance that we're ready. And one question from me is, in the risks section, our CQC lead has presumably left at this point, the council, so you must have assigned somebody else into post and
Yep.
or into that position. And I guess I'm asking for your confidence and assurance on that.
Yeah, so in terms of, so we have someone now in that position. So we have Elaine Taylor, who is the head of improvement for adult social care, and she is leading the CQC preparations. There's still an awful lot to do, I would say. So, you know, it would be a very brave DAS who would come in and say, you know, that everything is absolutely as it should be, and it's new for everybody who's going through the process. So, you know, what I can assure you is that yeah, we have plans in place, and we're working to try and make sure that we have those things in place, which will enable us to have a good inspection.
I appreciate that. Councillor Runson.
Thank you, Michael. Just two questions, Michael. The first one is the Health Watch report ready? Is that coming in on time? So we'll have it when we need it. That's the first one.
Yeah. So Health Watch, yeah, they're being extremely helpful, and in terms of the work which they're doing with us to make sure that the citizen voice and voice of people with lived experience feed into the work which we're doing, then yes, that's in place and that's in train, and there is no expected delay to that.
And the second one, which is called Enlightened Self-Interest, will CQC want the opposition to be involved?
So it's interesting what we've learned from pilots and the people who are recently going through this, that their real focus, I think, when they're on site is around frontline staff and understanding what it is that people are getting from services. I think they're less interested in presentation from the DAS and talking to the more senior people, and I think more interested in trying to look at what we've presented publicly, what we've got in our information pack to them, and testing that out in terms of what people's experience is and what the experience of the front line is. So I think that will tend to be their focus.
Thank you.
Councillor Vassey.
Thanks, Chair. Yes, I read this with interest. There's not a huge amount in it, but it sowed a couple of seeds. So paragraph 11 interested me. There have been 5 pilots. It says lessons have been learned. And it got me thinking, with energy, which is an area that I've spent more time with over the past decade, we've got an international organisation called the Covenant of Mayors that encourages 12,000 cities to share sustainable energy action plans, which enables people to learn from each other. And when I read the words here, lessons have been learnt from these, I thought, well, where are those lessons? Can we see them, please? I think it would be helpful for us as scrutiny members to get a sense of what has been learnt elsewhere, and to get a sense of from you as to how you think this council can learn from best practice elsewhere. Because one of the things that perennially frustrates me as a councillor is the kind of sense that sometimes we don't even realise there's a world over the city walls, and we just feed on each other for information and don't get the benefit of what other people are doing. And there must be dozens of comparator cities that we could be learning from. So if you could give us a sense of how you think this might feed into helping us develop our services, that'd be good.
Yeah. So yes, so there has been work which has been done around what's come out of the inspections so far, and those are now, you know, they're public documents as well. So Gabrielle, before she left, pulled those together in terms of lessons learned, which has been shared locally, and there's also been some sharing of that nationally. So I can very happy for that presentation to go out and with a bit of commentary on that. I think the bit about how we learn from each other. What's very likely to happen is that the work which has been done previously around sector-led improvement, we won't lose that. It will just change, so that previously when we did peer challenges, we would you'd pick what you wanted to look at, and we've done them about safeguarding and around use of resources previously. I think, you know, what is already happening is that's largely pivoting to the sector-led improvement being about you know, what's the best way to you know, kind of genuinely approach the CQC inspection regime, so that we do a good job and show we're doing a good job. And so that's you know, conversation which is happening with ADAS and the LGA and with local partners, and I think that's the approach which will emerge, is that the focus of sector-led improvement, certainly the adults world, will shift into this area.
Can I follow? So from that, and again, this is what makes me, what I end up thinking when I read this kind of thing. At a previous meeting of this committee, I was heartened by seeing dentists and other healthcare providers talking about how they sought to use the integrated care system to work together to find new ways of, for example, saving money by setting up joint primary care centres that would enable people to work better, save money, so on and so forth. Do you see this working, or shall I say, how do you see this working with the concept of integrated care going forwards, with the object of making things more efficient and more effective?
Yeah, so I think from a regulatory perspective, it's useful that within there, particularly in the providing support theme, there is an emphasis around working in an integrated way. So that is very much something which CQC will be interested in. And then from a perspective of a resident, they want to be able to see that the adult social care provision is integrated in terms of the other provision around them, so that they're not having to tell their story multiple times or be passed from pillar to post. So I think that the way in which regulation is set up is helpful in that aspect as well. And I think more generally with CQC, they have an interest in work in how systems work. So previously when CQC had been in and did the inspection of the hospital and the number of issues which were found there, there was very much a view that if you've got a hospital in trouble, then it's a system issue. It's not just a hospital issue. And so in terms of the improvement plan around that, very much adult social care was involved in that. And what I would hope to see is that in terms of either the success or challenges that come out of CQC, they're very much seen as system challenges, because the health of adult social care is dependent on what goes on within the health system and in the council more widely. So there are a number of other things which are happening in York, which are good, which I think will help with CQC. So we're doing work around frailty hubs jointly, which is providing some really good support to our community. Move towards mental health integrated hubs as well. One team approach around discharge from hospital. So there's lots of pieces around integration. I think where we need to strengthen is probably around some of the integration system around joint commissioning and those kinds of issues. But we have work in progress around that too. So to answer your question shortly, I think it's helpful in terms of the integration agenda.
And sorry, just finish off. So you've got the great advantage of having been here just a few months. And I always think to myself, when you arrive somewhere is when you actually have the clarity to see what it's about before you get sucked into it and it all becomes habit. So are there particular things that you say to yourself now with this opportunity and being imposed, this is what I would love to see in 3-4 years' time as the result of this tangible benefit of integrated care?
Yes, I've been around in the York system for a long time, yes, so I'm sort of new in this role in an integrated way. So I see lots of opportunity in York for integration, and I think there are a lot of new faces in York, which is good. So in terms of the ICB place, we have some really good thinking there, which is about how do we make the best use of the York pound effectively, and how do we think about how we join up in terms of everything from our early intervention and prevention services right through to the people with the most complex needs, and that joint commissioning forum has been established to do that. And will feed into the York Place board. So I think there's a lot of ambition around, and I think that there is also there's a sort of a driving need for that, because like the local authority, the ICB is in an extremely difficult position in terms of its finances, and so somehow we have to make sure that we don't duplicate, create inefficiencies, and we make use of our joint funding together. So I have a good degree of confidence. We've got some good people who genuinely believe in that, and it might be useful to at some point in the future to have something come jointly from the council and the ICB around integration. That might be something which the committee might want to consider.
Thank you.
Okay, members, we're asked to note that report in preparation of the upcoming CQC inspections. So thank you, Michael, very much for that. I appreciated the answers to those queries as well from Councillor Bassey. Okay, we're going to move on to the All Age Commissioning Strategy, which is item number 7 at page 67. Welcome Abid Mumtaz to the table. Abid, I'll start off really nicely and say you are now our favourite officer. You take the mantle from Peter Roderick. You're here at the death again for another meeting. And so that's the nice part of what I've got to say done.
Is there a bad Bob?
Oh, yeah, it will, but I'll let you introduce the report now.
Thank you very much, and thank you for inviting me back. So the All Age Commission strategy, and obviously I was sat in the back as part of the finance discussion, and I know there was a lot of.
I'm sorry, Chair, I'm not catching it.
Oh, sorry.
Thank you.
So I was sat at the back listening to the finance discussion, and there was a lot of things around. It's going to fall off in a minute. Around market management, engagement, value for money, and all of this needs to be hooked onto a strategy where it previously wasn't. So I arrived at York at the council 12 months ago, actually last January. And going on to the comment the council made earlier, it's easy to see things once you first arrive to see actually what's missing and what needs to be done. And one of the key things that was missing that I asked for actually where's the commission strategy and what's our principles going forward? There wasn't one, so therefore it was the first thing I developed. And I suppose the other parts of that is I need to ensure that there's a clear message internally as to the council, but then also externally to our customers, to our providers, to say these are our priorities and these are our specific outcomes. We've just heard from Michael around CQC, so I don't want to be having that CQC conversation to say, where's your strategy? Sorry, you don't have one. Then also, I'll be new to the team. I want to implement new ways of working and be able to adapt that. One of the things I do need to make the committee aware of is it is a live document, so therefore I am adding to it. So I'm currently doing a priority around send to ensure that there's a clear line with regards to what we're doing operationally to what we're doing strategically. The purpose of the strategy is a very simple purpose. It clearly outlines our approach to commissioning. It embodies our strength-based approach, looking at our community assets, looking at what we can do rather than what we can't do. I've tried to focus it on quality, so we know from a quality perspective that if we have increased quality, we have better outcomes with regards to what people can do and can achieve. From a data point of view, so the context section, I've included data around the JSNA, Public Health Intelligence. Legal context, we've obviously got the Care Act and the Children's Act that we need to take into consideration what we do. The ambitions are very clear around being able to support individuals to live their best life now, but also in the future. I've ensured there's a golden thread, so from our council plan down to the commission strategy, we don't want to be in a place where the outcomes weren't aligned. Commission vision is around person-centred, outcome-focused, and a sustainable market, and ensure it is fair but also well-led. Some of our principles around quality, responsiveness, ensuring that we meet needs, but also being an evidence-based approach to what we do. Financial limitations, again, one of the previous conversations around finance, so I need today a clear message to the market with regards to our financial limitations, just to reset some of the expectations. Partnership working, we're in a different place now to where we were previously. Obviously, we have the ICB. I wanted to ensure that we are in the driving seat, and that's impossible to do where you can't actually strategize where you are at the minute, but also where you want to be going forward. OBA, so that's a new process I put into place with the team. When I first arrived, we were very good at counting beans, but we're actually about measuring specific outcomes. Demographic information, so the commissioning cycle, we analyse, plan, secure and review. You can't secure unless you've analysed what you need, and we need to drive that. The market can't drive that, which is what I was seeing previously. Some of the priorities are around prevention, safeguarding, market development. And then for added assurance to the committee is below this strategy. So I didn't want to write it and then it gets parked. So below the strategy, I've got a commissioning plan, and that's updated on a quarterly basis to say actually where are we with our priorities, what's the trajectory look like, where are we off track, and what do we need to be doing differently.
Thank you, Abid. Okay, so I will look to members for any comments or queries where I can kick off and say thank you for running through the report. It's come to us as a committee after everywhere else. So I've noted that it's gone through executive, it's done health and wellbeing board. And in that respect, you know, if there's anything that members want to contribute, you have made the point that it's a live document and there's a plan underpinning it as well, that you're working through quarterly. So I think with that in mind, it is good that it's come to committee. So I appreciate that. And so if any members have got anything to add on that point, then that's great. I do. And so I guess it might be the wrong place for, I'm reading it through and thinking, well, where are the references to wages and ethical care, commissioning, etc., working with trade unions, such as those types of items? And I know they're in the social value policy that the council holds, so you may feel that they don't need to be in here. But for me, delivering high levels of quality commissioning is delivered by staff, and I just wondered if that's something that you do feel needs to be part of the plan, or whether it's covered elsewhere in the council.
And it is somewhere else in the council. So the other thing that was missing was a market position statement. So to go hand in hand with the commission strategy, I also developed a market position statement that goes through some of the areas that you've articulated. And that's also on our website.
Yeah, no, I appreciate that. I just so those are my points really. Has any members got any further points? Councillor Bassey.
Thank you, Chair. To be fair, I think this has come on the agenda. To be fair, this has come to scrutiny several times over the past years.
It has.
And we've discussed it with Jamila previously and stuff like that. So much of this, for me, is familiar, and I welcome it. I had a similar question, I suppose, to you, Chair, that at previous discussions on this item, we've discussed the fact that this document will be used around the table with other organisations, and whether there was a risk in it all being high-level aspiration, that there would be a lack of clarity when it came to negotiating. And there was the concern expressed that, you know, when you're sitting down with Lincolnshire and East Yorkshire and whatever, if you don't have clear targets about this is what we want to achieve with this particular thing, you've not really got anywhere to bargain. So I suppose my first question would simply be, does that appear elsewhere? Is that in the plan? Are there other documents that set out with more clarity targets that we wish to see in particular areas?
Yeah, I suppose there's several responses to that. The first part of it is there was no clarity before the commission strategy because there was no commission strategy prior to that. So that adds a layer of clarity.
Yeah.
The second part of that is we have, as referenced, we do have a market position statement that clearly states that this is where we are as an organisation. This is what we want to see more of. This is what we want to see less of. Because again, when I first arrived here, it was very clear that we were being driven by external forces rather than us actually being the customer. So I've had to reverse an awful lot now and manage that market, but also manage the key partners and stakeholders. And without having a strategy with our clear aims, objectives, and priorities wrote down somewhere, that would have been even more difficult and challenging to work through.
Thank you. So that goes some way to answering that. And it would be good at some point for us to see that document that you're referring to there, so that we can understand that position at a future meeting. But the other point I'd make is that there's practically nothing in it I disagreed with. And as I say, I've seen it a couple of times over the years. There was just one thing on priority 9 that in a sense goes back to comments I made earlier, which was about technology. Was it priority 8, sorry, maximising technology. Again, this goes back to discussions that we'd had. And I think earlier in the year, we said we'd be looking towards having a discussion on technology, on how it can be used to help a variety of people. The one thing that was missing for me in this, at this high level, was a commitment to ensuring that the technology that we use is presented in ways that are intelligible to service users, to avoid causing fear and distress, and to make sure they can all use it. And I say that, it's not declaring an interest. I say that as someone who in my family has someone who is now suffering from the issues surrounding old age and becomes very agitated with technology. And just the idea that something is digital causes problems. And so it's incredibly important that we both embrace the technology as ways of liberating ourselves to provide a better service and ensure that the people who are going to use it and the families of those who are going to use it feel comfortable with that technology so that we can move forwards positively and not get lots of negative kickback that hampers us. So my recommendation, Chair, and I'd like your comments on whether you think it's a good idea, that priority 8 should have something in it that recognises the need for those technologies to be accessible and intelligible to the users.
Yes, of course. So a couple of responses. So from our perspective, obviously, maximising technology is a key priority of ours, and I know Michael's is. We have a separate working group that looks through that, and then what I can do is put in some of the outcomes and outputs from that working group into a further chapter into this. I'm more than happy to do that, but then also realising technology isn't for everybody.
Yeah, it's just an acknowledgement
Yeah,
of
of course.
that as one of the parts of that priority.
And then I'm more than happy to bring back my market position statement announced at 8 o'clock.
Thank you, Chair.
Thank you. We do have on the work plan reablement technology or reablement. So some of the technology scheduled for May. So some of those points should come back at that agenda item in May. You referred to a working group on this strategy.
And on technology rather than the strategy.
On technology,
yes.
Okay. And so the points that Councillor Bassey can be taken to that working group. Okay. Is that okay, Councillor Bassey? Fully support that. Okay. Anybody else? Councillor Kelly.
Thanks, Chair. Yeah, I just had a question about the implementation of this, and how will you actually measure progress against what's been set out in this? 'Cause I think that was something that I felt like was missing. Just thinking about how we're going to be able to revisit against the outcomes that we're looking for and how it's going to work in reality. I think especially in terms of co-production, there's a risk that it can become a tick block exercise rather than being like a genuine exercise where service users feel the benefit of the collaboration.
Yes, of course. And that, I think I skimmed over it, but below this there is a commissioning plan that sits within the team. That isn't a public facing document for several reasons. There's a lot of risks, and I know the things are clearly articulated within that. But I'm more than happy to bring an updated version of that at any point in time. That's not a problem. Then with regards to your comment around co-production and tick box exercises, as I've tried to articulate that, we are trying to work differently from a commissioning perspective. So being able to co-produce services, because that's what the services are for, is really important. But it's also as important to not keep going to the same group with the same questions and getting a different group with some separate questions. And also ensuring that we work on a system level rather than just looking inwards.
Okay. Any more from members? Councillor Rose.
Yeah, I just want to say I think it's a really good document. I think it says a lot of things in plain English that we often say in complicated English. And there's a lot of points throughout it that I think makes it accessible to people who usually wouldn't read documents like this. The only thing I think in terms of that sort of framing or potential improvement, having gone through everything else, I'm not expecting this to change, but I guess there's a kernel of something in it. Talks as kind of prime principle of helping people and your communities become secure, independent, ambitious, and able to lead the best lives possible. There's something for me in the best their life possible, right? The best of them, and talking about things like the social model of disability, talking about people having to make accommodations in their own life to fit in, and a lot of the support being how to help people cope in their situation and for them to learn how to adjust themselves rather than a focus where possible on us adjusting things for them and making sure that they can lead the more natural life. So just there's something in there about it not necessarily being the best life. It kind of is implied throughout the text, all the way along. But yeah, it's a minor point really around possibly semantics, but I think it's the lens through which we view everything of how do we make them feel like their primary way of operating is as normal as it can be, because people just have different lives, and that's you know.
Yeah, and the reason I'm smiling is I wish I'd given you a draft version, because you've clearly articulated that better than I have in the document.
I think the point is made throughout the document anyway, so you know, it doesn't need a change, but I just guess when we're looking at the wider piece, it's good to kind of make sure the point.
Thank you, Councillor Bassett.
Just a minor point, but I was wondering while I was speaking to you earlier, why I was mixing up the priorities, and I've realised what it is. There's a typo in the document, so it's just to point it out in case it hasn't.
It's changed on the website.
There's two priority fours. Okay. That was just a minor thing, Chair.
That's good.
It's been rectified.
Good, it's been spotted. Okay. Committee's asked to note the strategy. I'd say thank you for bringing it to us. Welcome that it's not a legal requirement, but that we do have one. That's if that helps to inform your work with partners to the betterment of the council and the city, then I appreciate the time taken on it. There's nothing in it that, you know, I think anybody can disagree with. So it's a good piece of work done. We will ask you to pick you up on the market strategy,
market position
statement, and also in some form a way to look through how you implement something like this through your commissioning plan. That'd be good. And I'd also just welcome your work in the whole area. As I mentioned earlier, direction of travel on reablement, as we discussed 2 meetings ago, was really, really welcome. So thank you very much. Okay, Councillor Rose.
Yeah, just a note, that's the wrong word to use, but it says to note in the recommendations, point 3, in options, point 6.7, it then asks us to approve or not approve. So I'm just starting to checking if that is what we're supposed to do, or if we're just supposed to note.
Yeah, I think I'm going to skirt over the options and just say we're good to approve it. Recommended that we're noting it today. Yeah. Thanks, Councillor Rose. Thank you, Abid. Going to move to the work plan. Okay. It's page 99. I'm going to talk people through this. James done a lot of work on it with officers and directors to try to just thrash it out and work out where the bullet points are going at the end. I can run through it and pass over to you for any clarification if you want, James. Okay, so I'll go through March and say that we're working on items 1 and 2. Housing do want maybe some more specifics about what we want to discuss within housing delivery programme. And I think that's kind of fair enough, but a general status update I think is easy to ask for. On the second item, homelessness and rough sleeper strategy, I've spoken to Councillor Pavlovic about that. We are still unsure whether it would be possible to get that for March. but it is still a question mark. So it could happen, it might not happen. What I'd propose to committee is that we could only really take one of those two items because they're going to be big items. So I'd ask that you leave it with us to work out whether to have housing delivery programme or the homelessness sleeper strategy. Building repairs has widened significantly. It will be a substantial item. We've received some reasonable requests to include a couple of items within it, both from officers and from members. So it will include damp and mould, including AWAB's law, which Councillor Vassy, we received a request from a member to ensure that this committee was aware of and working towards AWAB's law, AWAB being the little boy in Rochdale that died from respiratory condition related to damp and mould. So that will be included in the building repairs report alongside no win, no fee solicitors and a housing stock survey and asset management that will roll into it. So item 4 there will roll in. So I think that's quite a substantial agenda for March. Do you want to add anything there, James?
Yeah, I guess just briefly, just to say that of those suggestions for building repairs, those items, I think with the exception of Awab's law, those were suggested by officers, so something that could go in there, and that it was their suggestion to kind of bundle asset management into that, because there was some overlap.
Yep. Thank you. Okay, so then we'll turn to April, and that's all good, except we have added pharmacies to the agenda item. Spoken to the Director of Public Health, and he's confident that an agenda item around pharmacies can be brought to the committee, and it's likely that that'll be led by the Integrated Care Board. Do you have anything to add on that, James, about who might be able to attend?
Yes, so it would be I think Peter Roderick from Public Health, and then with I think colleagues from Public Health from the ICB and a representative of community pharmacies. I think Peter's thinking was to approach that item in a similar way to how the oral health item in the last meeting had been addressed.
Yeah, which strikes me as that was a really good agenda item, and well put together with good partners around the table. So if we can aim to do that with members' approval, we'll add that to the April meeting. And then we've got a May, which is not on the published agenda, but we can talk around what we may have proposed for May. It's the adult social care strategy, as Michael Melvin referred to earlier. Reablement more widely, not just reablement technology, but another look at where we are with reablement, but it will include technology as part of the report. And autism and neurodivergence strategy. Now we're looking to the ICB to work with the ICB on that item, and it might possibly be May, but we're really not sure because we need to have more detailed discussion on that with the ICB. And finally, not on your papers, but we've asked for a status report on home care, which could possibly come to May's agenda item. So that's everything. And fine, in the bullet points that are published, the only one that remains TBC, the only two that remain TBC would then be the learning difficulty provision, which we've heard a little bit about. It's been in our finance and performance monitor today. And the urgent care delivery review, which is an ICB led item. So again, we're working on what that will look like and how the committee can look into that item. Is that everything, James, on there?
I think so.
Members? Councillor Rose.
You can't stop me, sorry. Yes, two things to potentially add to the work plan. One of which is output from the LGA peer review, so that's not imminent, but when we're getting that back, there might well be things in there that is probably worth having on our work plan and working out what the right timing is. The other one was a piece around the lasting effects of the pandemic. And I don't mean long COVID specifically, but the bit we talked about earlier around the lateness of diagnosis and early detection and intervention, life expectancy per ward, all of that stuff, but also COVID and flu impact this winter. We had really low vaccination rates, and so the impact of that and what the result has been in terms of hospitalizations and deaths and that sort of effect. Where do we stand now looking ahead long term to next winter and beyond? Have we caught back up to we're almost in a normal year again compared to say 2018? Or is there a long road ahead of us? What do we need to still do? And I just think there's something around scrutiny of that, particularly because we had poor vaccinations this year. It'd be good to know what's happened over the winter as a result. And national data doesn't really exist anymore. So it'll be leaning on public health, I think, for all of that.
Okay, I think that's really reasonable. It'll drop. We can add it as a bullet point to our future work plan. It'll drop to public health agenda type item if we want to keep trying to segment as we have done, acknowledging some of the problems that do occur. Happy to take if there are alternative views on that, but I think, yeah, we'll certainly add tentatively the LGA peer review outputs as a bullet point. And also, as you've just suggested, lasting impact of COVID, and we'll discuss that with public health.
Of the pandemic, because I think it's not just COVID specifically, it's the impact on the fact they couldn't have early detection and all the things that had to slow down and stop in primary care.
Okay, that's good. Councillor Vassie.
Yeah, I know we struggle to go beyond April and the complexity of that, but I really do want to stress the whole re-enablement stuff. And I want to lift it beyond what we usually do. We tend to just trudge and plod along with our reports and do all of that stuff. What would actually benefit us is to get some external expert who really knows this stuff to give us a presentation that shows us the best of what's happening in the world today, so that we become lifted up and we can, instead of kind of trawling through hundreds of pages of text, we get a sense of what's out there. We get little hints of it from time to time. I remember a year ago, someone said there are people who make dogs like Canine Doctor Who available as kind of pet substitutes for elderly people with dementia. There must be loads of stuff going on around the world. And instead of trudging through this, I'd love to hear someone who's full of enthusiasm come and say, look, they're doing this here and they're doing that. And so that we all become lifted up and can see the world in a different way, because I think that eventually is what's going to enable us to address these huge costs that we have and transform care so that it works better in the home. So we've got time if we're looking to do this in May. Yeah. I just think, can we charge someone with finding somebody exciting to come and present something in May?
Exciting is just
a bit exciting.
It's a bit extra. I'll bring Councillor Baxter in.
I was just quickly going to say that York does have those dogs, because when I worked in Marjorie Waite Court and in Alden House, I got the fright of my life when I heard this dog barking. But they are really good, and we do have them in York, so we do have some exciting things.
So I think we need to see some of this.
Yeah, bring one in.
Yeah, I think it's a really good idea. It's very timely to think above. I really welcome the suggestion, Councillor Vassie. I'm sure the University of York have done a lot of work on this as well, so we'll pick it up. Happy to do that with James and directors, and we'll try and work on that. So it's not just a plod through, as you refer to it as. We can do that. Okay. I've got one last point to make on work plan, which is it's a bit of a throw it out there I had a lot of questions at Finance and Performance Monitor around home care and around commissioning care. And partly it's related to what I feel we need to understand in my request for a status report to May's meeting here. But I really feel that that's a long way away. I think I would certainly benefit from getting stuck into that item sooner. So I am proposing, first one, task and finish deep dive, not necessarily to make recommendations, but to gain a greater understanding. A lot of the commissioning, as the finance manager Steve Tate mentioned, you know, he can't put to us in this forum, but there's a lot of learning that members could do around the background. So I want to do that, and I need the committee's approval, and I need at least one other person to undertake that deep dive with me. You don't have to jump up now, but if nobody jumps up now, then what I'm going to do is propose that we do a deep dive into home care commissioning and undertake that now, and I will lobby you privately if nobody steps forward now. It would be good to do it on a cross-party basis as well, of course. So 1 or 2 additional members would be great. So I'm going to throw that one out there and leave it there for now. If we can make a note of that, James, I'll pursue it outside this meeting. Okay. Anybody got anything else to add on work plan? No. Okay, I think unless there's any urgent business, we're going to close the meeting. Thank you, members, for all your time. Have a good evening.